Mr. Chairman, ladies and gentlemen, I wish to thank the organizing committee for inviting me to this meeting and giving me an opportunity to review this important area of experimental and clinical medicine. And after having cleared my disclosures, I just want to call your attention on the concept that the approval of AAV-based gene therapies over the last years has been associated with a huge amount of publications. And we have defined two major directions pursued in those publications. First of all, the relevance of directions pursued in translational research to make possible these approvals. And here you see the directions pursued, which involve a series of public and private involvements in the area. Secondly, and more recently, another direction has been followed, which is mostly related to the best ways to advance the use of AAV-based gene therapies. And we have tried to analyze this more modern issue because this may be very important for AAV-based gene therapies in clinical medicine and in hematology, as well as to provide new ideas for the development of gene therapy in general. And let me start just by taking into account the advancing the use of the improved cassette engineering to advance the use of AAV-based gene therapy. A couple of years ago, a systemic review of clinical trials in AAV-based gene therapies has been published that covers over 149 unique clinical trials involving more than 3,000 patients over 20 years. And the general concept emerging from these studies is that AAV-based gene therapy is well-tolerated, successful, and safe treatment modality. Low-grade adverse events being reported in 20% of these trials, usually during the first month following AAV administration. And 1/3 of them were attributed to the vector components. Transaminitis was the first of such low-grade adverse events. It was determined in several hemophilia patients undergoing gene therapy, and it was very important to know that this adverse event has a very good response to corticosteroids, being mostly related to vector and transgene-specific T-cell responses to AAV transduced cells. Also, major adverse events have been reported, and they are summarized in this slide. In 3 cases, thrombotic microangiopathy was defined, which is a complement-related issue. In 4 cases, liver problems, in 2 cases being fatal, have been reported. And in reality, it is important to emphasize that in myotubular myopathy, there is an inherent liver disorder which has not been evaluated so far in detail. And that for central nervous system, 3 cases have been reported, 2 related to peripheral nervous system toxicity, and 1 related to central nervous system toxicity. Concerning the central nervous system, almost 1 year and a half after intracerebral injection, participants experienced T2 abnormalities consistent with localized inflammation and edema at the site of vector injection. And then they were attributed to vector or transgene specific immune toxicity. In contrast, in peripheral nervous system toxicity, severe neurological loss in the absence of inflammation or signs of toxicity have been identified at pathological examination. Two major conclusions of the systemic review are reported in this slide. First of all, in spite of its ability to increase average AAV doses to be used in clinical practice, in reality, second-generation vectors still may cause toxicity to the liver and elsewhere. Better cassette engineering is indeed needed to decrease the viral load needed to achieve therapeutic effects, which means to allow GT to avoid the liver and escape the immune control, and to make transgenes functional in a very narrow setting of cells. The second conclusion is related to the observation by the authors of the review of the uncertain durability of the GT response, and in his sense, in his direction, they argue for long-term, potentially lifelong follow-up data in settings without rapid transgene decline, and in conditions where steroids are used in some cases, of course, just to have differences and to single out the role of steroids under those conditions. Concerning the low numbers, the low number of cases of neurotoxicity, the data have been further analyzed with emphasis on preclinical studies, especially animal models in non-human primates. And two major data emerge in this respect. First of all, that AAV-associated neurotoxicity occurs in general in animals treated intracerebrally, which means locally. And this is true in general. However, it is also true that when you increase sufficiently the amount of AAV doses to be administered systemically, say intravenously, you can achieve the same response. And secondly, that the amount of genes, of transgenes or whatever you use are dramatically higher than the ones you use in AAV-based gene therapy in hemophilia. In both cases, impurities are only defined as contributing factors. This is the reason why the authors claim for GMP grade vectors to be used in preclinical studies in order to allow preclinical data to be useful in humans. Concerning the mechanism of neurotoxicity, data are accumulating to show that non-human primates receiving steroids or immunosuppressive therapy still display neurotoxicity despite the ability of these drugs to blunt vector and transgene-specific immune responses. And this calls for two major directions to be followed to understand the observation, the clinical and the experimental observations obtained. First of all, unmethylated CpG motifs may trigger per se an immune response via the toll-like receptor 9 mediated recognition. And it is also true that the lower the GPC motifs within the vector structure, the lower the risk of innate immune sensing and of specific T-cell responses. And this has been also documented in humans. The second direction to be pursued is related to the fact that in general, neuron degeneration and neuronal toxicity occurs preferentially in cells with the highest transgene expression. This calls for protein response for stress-induced apoptosis following the unfolded protein response pathway, which is a major mechanism for the control of the of protein function and protein structural integrity. Now, presently, we have no information whatsoever whether high levels of transgene messenger RNA or the protein itself is involved in these events. However, it is very clear that this direction appears to be very important also in evaluating mechanisms involved in liver toxicity in AAV-based gene therapy in hemophilia. The second direction that has been pursued is relative to the extensive requirements for the pharmaceutical industry. In regular drug treatments, we are used to think about manufacturing costs, quality controls, removing impurities, and so on, as key challenges and major determinants of product costs. In reality, in AAV-based gene therapies, other additional directions should be explored. First of all, the need of ad hoc clinical endpoints to be designed, tested, and validated in clinical conditions where there is no previous treatment available and where you need to have some very clear endpoints to evaluate the efficacy of a treatment. Secondly, you need to have trained treaters for AAV vector genome administration, for instance, subretinally or intracerebrally. The long-term, the 5-year experience with Luxturna was very important for defining additional requests for pharmaceutical companies as far as the post-marketing requirements are concerned. First of all, you have to have a huge amount of centers of excellence to treat patients, which means you need standard, very careful and detailed standard operating procedures, very well organized training programs for treaters, and you have to board certificates qualified operators. In addition, drug companies are also requested to share both positive and negative data and provide original results in order to maximize safety and potential benefits of GT from one side and to avoid to repeat harmful or unsuccessful studies. Long-term analysis of the ex vivo treatment of adenosine deaminase deficiency causing severe combined immune deficiency extends to ex vivo gene therapies the relevance of these concepts and also adds additional requests and additional challenges for the pharmaceutical industry in order to make this strategy accessible to patients worldwide. It means in reality to set up adequate manufacturing capacities for the needs of the expanded market, to guarantee long-term monitoring and vigilance, to maintain cost-effectiveness of personalized treatments. The third direction that has been pursued is related to patient selection and clinical improvement endpoints as critical variables for clinical product development. This is a very important issue in view of the fact that, for instance, in hemophilia now, we are discussing a lot about the relevance of this issue. In situations such as hemophilia, where the number of patients is rather limited, you cannot have case control studies to evaluate the efficacy and the safety of a treatment. What we do in general is to know very well the nature of history of a disease and to define based on it very specific endpoints to be analyzed in order to evaluate efficacy. Information from another very important hematological clinical condition I refer to, transfusion-dependent thalassemia, provide very important information concerning the question of the natural history and patient selection. And I will discuss with you two issues specifically emerging from long-term studies in this area, which may be very useful for hemophilia gene therapy. First of all, patient selection. In transfusion-dependent thalassemia, transfusion support starts when kids are almost six months old. In reality, the earliest enrollment age is 3 years, which means that for 2 years and something, these kids are exposed to iron overload. Their liver are exposed to iron overload. The upper age limit for gene therapy in this setting is 35 to 50 years, which means that for say 35 to 50 years, not only the liver, but also lungs and also the heart are exposed to iron overload and fibrosis. That's the reason why the authors in the area insist on the need to use age plus full organ assessment to identify the optimal patients to be treated with gene therapy. Secondly, in hemophilia, we discuss a lot about whether to strive for normal rather than therapeutic levels of factor 8, factor 9. Now, in transfusion-dependent thalassemia, an important information is provided in this respect. Indeed, the authors there insist on the need to maintain hemoglobin levels persistently above 10 grams per deciliter. Otherwise, you just transform a transfusion-dependent hemophiliac into you convert in reality convert a transfusion-dependent thalassemic into a transfusion-independent thalassemic, a condition in which, in reality, you have iron overload due to increased intestinal absorption, which means that in reality you are unable to avoid under those conditions hypercoagulability, risk of strokes, and so on. And this may be very important for the discussion that we are doing in hemophilia. There is an additional issue that emerged from this studies. As I told you, this is an ex vivo gene therapy in which lentiviral vectors are employed. Now, the authors strongly emphasize that none of the patients treated with new lentiviral vectors have developed any leukemia or myelodysplastic syndrome, which is very important for the sake of the argument and for the future of gene therapy in hemophilia. And we will come back on this issue in a few slides. In conclusion, Mr. Chairman, in spite of the idea that gene therapies can diverge on design and endpoints, and that based on the mechanisms, informative outcomes may also differ, which is a common tenet now in gene therapy. Some broad conclusions are supported by the majority of the studies, and we have summarized this data in the following 3 slides. First of all, the need of an improved cassette engineering. AAV capsid variants with improved tropism for the target tissue should be defined to lower doses and to lower treatment-associated toxicity. This is also important to reduce GPC motifs within the vector and the ITR and limit immune recognition. This is a direction that requires very good capsid libraries to be employed. The second issue emerging from this improved cassette engineering story is that presently antisense and gene editing strategies are expected to complement gene augmentation to provide permanent solutions in conditions where AAV-based gene therapy does not suffice per se to resolve some issues. In view of this and in respect of this issue, we need to know which is the optimal result, the maximum result that we can get just by using the AAV-based vectors in order to know when and to start and in what conditions to start this type of complementation. The issue concerning the requirements for the pharmaceutical industry in reality requires to align the interest of drug companies, of pharmaceutical industry, with the interests of the health system. Health system in this respect requires pharmacovigilance and long-term follow-ups and to maintain cost effectiveness of personalized therapies. There is an additional issue that should be taken into account in general, which is related to the emerging issue, to the very important emerging issue of gene therapy treatments for all. Now, from this point of view, it is very important to think about developing countries as a direction to be pursued. In respect to this, tailored approach to costs and payment systems are required in order to make this GT treatment for all accessible. And the other issue to consider is related to the patient selection issue, which means to the natural history. In reality, we believe that these days, just to pursue the specific issue, we should consider that an appropriate selection requires analysis at the molecular and cellular levels. This is the level. This is the only direction that we believe can be pursued to define the role of manufacturing, treatment, and patients-related parameters as to outcome, safety, and durability of gene therapy. The second issue that is emerging among long-term goals that are summarized in this part of the slide is related to the complementing issue and to decide to introduce new complementing issues to solve, new complementing strategies to solve unsolved issues. And this is going to raise additional problems to be solved. In reality, Mr. Chairman, what is clear at this stage of the game is that we can start thinking seriously about the possibility of improving or further improving AAV-based gene therapy to improve in general gene therapy and the impact of gene therapy on the future of medical practice. Thank you for your attention.